Hi, I'm going to go over these slides so you have them as a backup, but Connie should be going over all these in class. So I hope you have a good week. So chapter 12 talks about the postpartum physiological assessments in nursing care. All right, so I'm not going to read the objectives. I'll let you read through these. Okay, so focusing on postpartum nursing care. One of the things we want to do is have a woman have a nice and smooth transition after she has her baby. This is a wonderful time. We do call the postpartum period the 6 weeks period after childbirth. So women go through a lot of changes. We hope that their body can start to go back to their pre-pregnancy state. And women who are healthy, this is pretty much the usual course. Women who have some pre-existing conditions may take a little longer. And women who've had a traumatic birth versus a pretty low risk birth, that will all play a role in how she returns to her normal state. So after the baby, after delivery, the reproductive system goes through some dramatic changes as well in this first 6 weeks. So women are at risk for a couple of problems, infection and hemorrhage. Those are the two big things we worry about after for postpartums. So the uterus will start to begin its course back to a pre-pregnant size, shape, and location. The placenta site will heal, and we call this involution. This will happen based on the hormones. The women that are breastfeeding can feel a lot more of this, but after those after pains, we call them, after pains during the first few postpartum days, they're usually moderate to severe cramp-like pains, and they happen more often when we're breastfeeding, okay, when the baby gets suckling on the breast. Oxytocin gets released and it clamps down on that uterus to try to bring it back and compress it back to its normal shape. So one of the things nurses have to do is assess that uterus every 15 minutes in the first hour, every 30 in the second hour, and every 4 in the next 22, and then it goes to Q shift. We're looking to make sure that the tone and the placement of the uterus is good. So uterine tone, we want it to be, firm. We don't want it to be boggy uterus. And then we want to note where it is at the umbilicus. So the umbilicus is sort of our landmark. Where does that uterus fundus of the uterus fall compared to the umbilicus? Okay, and you're using palpation with your two fingers to try to find it. If it's boggy, you can actually massage it with your whole palm of your hand. But if it's not boggy, then we just kind of gently palpate it, and then we can measure where it is within a centimeter's length of the umbilicus. So for the endometrium, this is the mucous membrane that lined the uterus. It exfoliates and then regenerates after birth of the placenta, and it kind of goes through a sloughing off of these tissues that were built up there. Women will have a bloody discharge. We call it lochia. And this has some of the tissue that comes out of the uterus and some of the placental fragments, and it'll start, those contractions, of course, will constrict that area. So the blood loss, usually it's not excessive, okay? In the beginning, in the first day postpartum, there should be some moderate, but it shouldn't be excessive bleeding, okay? If there is excessive bleeding, we worry about a postpartum hemorrhage. So we're going to start to check that fundus. Is it firm? Is it boggy? We may need to do some measures to reduce the bleeding if it is bleeding a lot. Make sure you look at those critical component parts in your book. So again, heavy lochia is a sign of excessive bleeding or hemorrhage, and we need to check the tone, of the uterus, and we also, are assessing where it's falling in the umbilicus. This is a picture of the nurse assessing the postpartum uterus, and this is something hopefully you'll get a chance to do in our rotations through OB. If you get a chance, if a nurse is going in there to assess a woman, please ask her to explain and allow you to do it. So she could do it first, describe it to you, and then you should be able to have the opportunity to do it as well. But again, the umbilicus is our landmark, and we're trying to find it in comparison to where that umbilicus lies. And if you look at figure 12-2 on page 312, you can see that different days that uterus is moving down in the abdominal area. Again, here's that picture, 6 to 12 hours postpartum, and then several days out, it's going to come down, okay? Here are some pictures of the lochia, scant, light, moderate, and heavy. So this is something we're also assessing. We're also assessing the smell. We want to make sure it doesn't have foul odor, because again, that's a sign of infection. Bright red, copious amounts we worry about. Okay, and the vagina and the perineum also go through changes depending on, was it a traumatic vaginal birth? Did they have a tear? Did they end up with an episiotomy? So looking at the acronym REDA, we're going to be looking for redness, edema, ecchymosis, discharge. Any of those things we're documenting, we're assessing, we're teaching the woman through all this about what we're looking for. We want to look for, if they do have an episiotomy, that's a cut that the provider will make, the midwife or the provider, in the perineum to make more room for the birth. We want to make sure that that's healing and approximating well. And they also may have pain. We can obviously put ice. A lot of women like ice. A little bit of ibuprofen is good. Also, we can use a sitz bath. If you haven't seen what a sitz bath looks like, please ask your clinical instructors to show you how that is set up, and it works really well for women. They enjoy that. We can also use a topical anesthetic or a peri bottle with warm water. That feels really good as well. I'm going to let you take a look at the clicker question through here, so I'm not going to go over that. Okay, one of the big changes women go through postpartum is their breasts change. Of course, there's some engorgement during pregnancy, and then colostrum is that, first baby milk. That's really important because it has all of the nutrients and immunizing kind of properties. The women will already have some primary engorgement, and it's an increase in the size of their vasculature of their breast, lymphatic system of their breast, but this usually precedes their milk production. Milk production is not going to take place for another couple days, so once 24 to 48 hours, that women will start to feel the breast milk, the milk coming in, and their breasts will get much larger and engorged. And they're often very tender, and the first few times that baby's, getting onto the breast properly, it's clamping down and it really hurts quite a bit. So we do have to teach mom proper latch, and there's quite a few things about breastfeeding that we'll talk about in another slide set. But we monitor for mastitis. That is a complication of breast engorgement, and we treat that. Basically we want to put heat on that, monitor for streaking of redness, and then women will often go on antibiotics as well. So immediate postpartum, all the body systems pretty much going through changes. So the cardiovascular system, they probably lose about an average of 200, 500 mLs of blood from the birthing experience. Their cardiac output will start to return to normal, um, within the first 48 hours. So they might have an increased heart rate, but that should settle down. Their white blood cell count levels will increase to 25,000 millimeters within a few hours after birth, related to the stress of labor and birth, so that's normal. And then they return within 7 days to normal white blood cell counts. Women are at increased risk of thrombosis because of the increased circulating clotting factors, and these will start to decrease after birth of the placenta and return to normal within 2 weeks postpartum. A life-threatening complication would be a thrombus formation or a pulmonary emboli. Orthostatic hypotension is another complication that could happen, sudden drop in the blood pressure when the woman stands up. So the first time she gets out of bed, the nurse should be with her. Help her get to the bathroom, walk around a little bit. A lot of women will feel this episode of feeling cold and shaky the first few hours after birth, and the phenomenon is called postpartum chills, and it's related to vascular instability. So again, you're going to be monitoring their vital signs every 15 minutes for the first hour, every 30 for the second, every 4 for the next 22, and then Q shift after 24 hours. Okay. Making sure, especially women are at high risk, again, for postpartum preeclampsia. So that still can be a factor even after birth. So we do have to monitor if they've been high before. We have to make sure they're not going to be high after. Their CBCs should also start to return to normal. I guess that's pretty much the big pieces. And temperature, assessing temperature to make sure that they're not running a fever. So just like all of our patients, these women need, their vital signs assessed, their lung sounds listened to. So we're going to be doing a good respiratory assessment. We're going to monitor respiratory rates. We do their vital signs. And everything should be within normal limits with breath sounds and breaths per minute 16 to 24. Breath sounds should be clear unless they have some pre-existing condition or there's a potential problem. Their immune system, a lot of women do have temperature elevations during the first 24 hours post-birth. There's a lot of changes happening, hormonal changes. They're exhausted. They haven't eaten. They haven't slept. So after the first 24 hours, it's not uncommon to see temperature of 100.4 or higher first couple of times. But again, we're going to be, if we see it after the first 24 hours on 2 occasions, we could potentially be looking at a postpartum infection. So that's when we obviously would notify the providers. Immunizations, any woman who is rubella non-immune should be immunized for rubella before discharge. And if they don't want to be immunized, they have to, of course, sign off, but they usually do agree to it. And then Tdap or any other immunizations are also open for discussion if they need them. This is an opportunity. Again, we get them in the healthcare system, and if they're behind on something, this is an opportunity to catch up. Very individualized, and will provide what they need. RH factors, we're looking, are they RH negative women? They'll develop antibodies to the RH positive blood related to exposure during pregnancy with an RH positive fetus. So these women again are at risk for antibody reactions, so we're going to consider giving them RhoGAM. And so Rh immune or Rh negative women will get it at 28 weeks gestation. They're given the RhoGAM. So let's see, and that Rh negative women who give birth to an Rh positive neonate are screened for the antibodies, and then a second injection is given to them if her Coombs test is negative. Let's see, RhoGAM. I kind of talked about that. A little bit of reactions to that might be pain at the injection site. Usually that's done IM within 72 hours post-birth is when they give it. So the urinary system is another system that has some potential problems the first few days postpartum. Incomplete emptying of the bladder is a common one, or inability to void. Those are two things. A decreased sensation or urge to void. There's sometimes trauma around the urethra. Diuresis usually happens during that postpartum within 12 hours post-birth, and that kind of gets rid of that excess tissue fluids. But some of the complications we need to look for are bladder distension and cystitis. So we can do a bladder scan. We can also, usually the fundus will be displaced if the bladder is full. So we usually try to get them up, have them void, and then we can assess their fundus a little bit better if we can't find it right at the umbilicus area. So again, we're going to palpate to see if they have bladder distension, looking for uterine atony, displacement of the uterus above the umbilicus to the right with increased lochia and fullness is a common one that we want them to get up and void. Okay, once they void, then we're gonna see that uterus go back to its proper place. If they're not able to void within 12 hours post-birth, they may need catheterization. We can get an order for a catheter. They can put in a Foley catheter, especially if it's swelling around the urethra that's causing it. Or we can do straight in and out catheters. Peppermint oil is a little trick we use. We put it on a cotton ball and we have them kind of sniff it, and usually it helps them to be able to go. Encourages the relaxing effect on the urinary sphincter. What else can we do? Increase their fluid intake. They should have a minimum of 8 glasses per day to try to flush out their system, so to speak. Here's another clicker question. This one's good because this one's similar to one you might see on the test. All right, the endocrine system. You're going to notice that there's lots of hormones in the endocrine system: estrogen, progesterone, and prolactin. So estrogen levels begin to rise after the first week of postpartum. Non-lactating women, the prolactin levels continue to decline throughout the first 3 weeks postpartum, and menses will begin 7 to 9 weeks after birth. And that first one is usually, the first menses is usually non-ovulatory, so they don't usually have ovulation until their 4th cycle occurs. But we'll talk about that. And lactating women, prolactin levels increase in response to the infant sucking on the breast. So lactation suppresses menses. So they, depending on how long they breastfeed, they won't have their periods most of the time. Ovulation is suppressed longer for lactating women rather than non-lactating women, but they should not assume that they're protected and use an alternate form of contraception, because it's not advised to only use only think that they're not going to get pregnant because, as a form of birth control, because it could be that they ovulate and it might happen. So it's not a guarantee. Okay, the muscular and nervous system. The muscle along the abdominal wall, the diastasis recti abdominis, um, this separation that happens during, birth, well, when the fetus grows and the muscle stretches out, it will become less apparent as the body returns to pre-pregnancy state. But they do have some soreness. Their belly becomes a little flabby. Some women look pregnant, for a couple of weeks after they actually deliver their babies. It's not an instant return. The nurse can usually feel that separation of the rectal muscle, the muscle, when assessing the fundus, but just kind of reassure the woman that this is normal and will diminish over time. It's not uncommon for them to have muscle soreness, moving around, positioning, but it certainly is, give them a little bit of Tylenol or ibuprofen, ice pack some areas if it helps, heat helps, warm showers, anything that you can encourage to, reduce some pain. So the GI system is also affected, where women can have constipation, especially if she's had, haven't been eating, or she's a little dehydrated, some fluid loss. Hemorrhoids is another common problem during pregnancy or the birthing process. These will slowly resolve, but they can be painful. And then women are usually so hungry after birth that they're like just starving. So they'll eat a lot of food right after. They can go right into a regular diet unless they're on some other type of diet, like for diabetes for example. And weight loss. So the women are really focused on the weight loss because they want to go back to their pre-pregnant weight. But this will take, anywhere from 3 weeks or longer. But they can lose an average of 3 to 4 pounds. Quite a few in the 6-week period before they go back to the physician. At the end of postpartum, approximately 3 to 4 pounds is on average above her pre-pregnancy weight. So she's not going to completely lose it all, but and some women do because they work really hard at it, and breastfeeding does help with those pounds, getting those pounds off. But as the nurse, you'll be assessing her bowel sounds, you'll be assessing for constipation, encouraging her to increase her fluids, her fiber. Did she have any hemorrhoids or problems prior to pregnancy or during pregnancy? Getting her up, ambulating her, and we usually have a stool softener that we give all of the women, the Colace, after. So this is the last slide I'm going to do, is discharge teaching. I'll let you look at the case study on your own, but discharge teaching is really big. Again, teaching for all the different things going on for women is really a big focus. But you want to talk to her and her partner about, things to report to the physician or the midwife. Possible postpartum hemorrhage can happen after they leave, so excessive lochia. You'll want to talk to them about potential for infection if their temperature is elevated, 100.4 or higher. You're going to talk to them how to care for their tears or any lacerations. Have them do pelvic, the Kegel exercises. If they have any blurry vision, headaches, remember that could be associated with preeclampsia. If their breasts become tender, warm, and reddened, so a red streak is the big thing that we look for mastitis. So that's another thing you could teach her. And then leg pain or chest pain or difficulty breathing could mean either a pulmonary embolism or a venous thrombosis. And then potential for depression, postpartum depression. So we want to talk to her about all of those things, if and potentially more if there are any prescribed medications. Sexual activity, we usually tell them that they can return to sexual intercourse when the lochia has stopped, the perineum has healed, and the woman is ready emotionally and physically to resume sexual activity. We also talk to them about contraception. Do you want to have more pregnancies? And methods of birth control, or options about sterilization if that's something that they're looking at.